So our project is using discrete event simulation to model the cognitive behavioural therapy pathway within an IAPT service. So my name is Katie. I work in Dorset Healthcare and I am a CBT therapist, so I'm in this pathway. We also have Hannah, who's helping me to present today. If you want to introduce yourself, Hannah.
Hi, I'm Hannah. I'm an IT technician in Dorset Healthcare.
And we've also got Matthew and Andrew who've been working on the project with us. And we've got Matthew here today. I think Andrew couldn't make it. And it's not on here, but Tineke was our mentor. And yes, lots of thank you to Tineke. So just to explain a little bit about the service that I work in. So it's an improving access to psychological therapy service called Steps to Wellbeing. We run across Dorset and Southampton, but for this project, we focus specifically on the urban Dorset area, just because it got a lot more confusing if we were looking too large. What would normally happen within our service is a patient would refer in, they would have an assessment, they would either be discharged or signposted somewhere else, or they would go forward for a type of CBT that we offer or counselling. They then might have further treatment or they would be discharged. We do have national targets for our waiting times and people being seen within a certain amount of time. And at the moment, our urban waiting list is continuing to grow. So over the last couple of years, it's gone from about 500 to now being 700. And the patients currently in treatment is about 750. So I've highlighted high intensity CBT because that's the part of the pathway that we are going to be focusing on. And that's because currently that does have the longest wait between assessment and treatment. So again, just to briefly explain a little bit about what would happen if they are going forward for high intensity cognitive behavioural therapy, they would either be sent through to an agency to access online typed CBT, or the therapists within our service would offer either an online group that they would attend, or there's one-to-one CBT, and that's available virtually or face-to-face. Now, since the pandemic and all the changes with COVID, we are running much more groups now. We have fewer therapy rooms that we can actually use, and we have fewer face-to-face evening clinics. We have one running at the moment, but we are slowly starting to, change groups to more face-to-face and looking at how we can do that. The average wait for one-to-one at the moment is about 6 to 9 months, so it is over the targets. There are shorter waits if patients are priority, they're going on a group, or they're going forward for online CBT. And we're estimating or predicting that the longer waits will be for patients who want evening and face-to-face appointments, because that is more limited at the moment. So that is the question that we were looking at from this project. So what aspects of the pathway are having the greatest impact on waiting times, and also looking at how we best allocate a therapist's resource and time so that we can improve the waiting list as much as we can. So what if we did change an evening group slot, which is run by 2 therapists, to a one-to-one face-to-face evening clinic? So that's the question that we were hoping to ask by using this model. So we were using discrete event simulation in Python. We were trying to create a model of the current waiting list and pathways for treatment. So the patients were passing through the model. We used a 2-year warm-up period because the waiting list doesn't start at 0 every day. And we ran the model for a year. So that's what we were looking at with the data. And we used appointments as the resources because it got really complicated if we were trying to use things like therapists or rooms or things like that. So appointments was the way we ended up doing it. And we were thinking about things like, what percentage preference do people want? Face-to-face, virtual, group, the online appointments. What percentage do people want evening, face-to-face appointments? How many groups do we currently have? Who's priority? And things like attendance rates and dropout rates as well, because generally it's higher for groups, so that might also impact things. We do have access to a lot of data within IAPT. I thought it'd be a lot easier to get the data for what we were using. It turned out to be a bit more tricky, but yeah, we have data from people currently waiting and also people who have waited and had treatment as well, and that's where we were kind of using for our model. So I'm just going to switch over to the model and Hannah's going to introduce you to it.
So this is the tool that we've developed, which we hope that Steps to Wellbeing are going to be able to use going forward to look at different sort of resource allocations and different types of appointments they could offer, and just see how that might impact their waiting times. So in the menu on the left, you've got all the different variables which are customizable. So the defaults are based on the data from the real world. So what was the situation that we're seeing at the moment? And then obviously they will be able to change those to reflect sort of any changes that they're planning on making or thinking of making in the service. So you've got all different types of appointments available and stuff in that column. So if we scroll down a bit, so the models run over the course of a year, and then so these are the number of patients that have been seen, so patients who have reached the end of the waiting list and then started their treatment or potentially even finished their treatment. So these are the mean wait times for each different type of appointment in weeks. So if we look specifically at the one-to-one face-to-face evening, you can see that they're waiting about 29 weeks. And then on the other tab, we've got the same data, same statistics, but for the current wait list. And then a bit further down, we've got some graphs showing the number of patients waiting over time. And you can see for one-to-ones, it is steadily increasing, which does reflect the real life situation. And then just a bit further down, we've also got just raw data, just in case anyone wanted to do anything with that, or just to help us when we're looking at the model as well. So Casey's now going to change, she's going to take away one of the evening groups and she's going to change that to be a face-to-face evening clinic. So that's increasing 4 appointments for the face-to-face evening. So that's just going to run now. It does take like a minute or so, but it's not too long.
We've met with the stakeholders, so the managers within my service quite a few times to get this sort of something they can actually use, and we do have data teams within our service. So we know that our service runs a bit different to, say, rural Dorset. They have more face-to-face available at the moment, and also their preferences are different. So a lot more patients there seem to prefer face-to-face. So that's why we have a lot of things that you can change on the left-hand side, because the preferences are going to be different in different areas there. So we met with them quite a few times. We've tweaked things for it as well. So this is the change, isn't it?
Yeah, so we can see that having changed that evening group into an evening face-to-face clinic, it has reduced the average wait time for the evening face-to-face patients. So it was 29, it's now 25. So from this, it does look like there would be an improvement. Obviously, we do still have some work to do in terms of like confirming accuracy and things. But you know, this seems to be going okay.
Yeah. So that is one of the things, if we think about what we did find out, we are still looking to tweak this model, because we've run it lots and lots of times now, and you know, there are a few kind of bits that we need to still look at, but generally it does seem to be going with our predictions that the longest waits in treatment are for evening or face-to-face. It actually looks slightly different this time around, but generally it is a higher number for those ones. So we also, you know, from asking that question, we've seen that it does seem to improve wait times by changing that evening group to a face-to-face clinic. So that helps the team that I work in to, you know, think about decision making and how can we start to do that if it's going to be helpful. So thinking about sort of learning and problems that came up during this project. So as I mentioned earlier, it was difficult to get accurate data from current wait lists. Turns out some patients don't express a preference until they're on the phone being booked in. So actually going through and trying to pull that data, I had to dig around lots of different areas and use current and past. And that happened with a few of the other things that we were looking at as well. So also the fact that we haven't really had any previous experience with coding. I don't work in data, so this is not, you know, my area. So it's been a really big learning curve, and we're still learning stuff at the moment. And we are still meeting with stakeholders. So some of the things that we are looking to improve on with the model is to build in multiple runs and then having like an average score come up. So running that model several times over to try and, get an average score. And also we would like to be able to have a side-by-side comparison of, the model as it looks, as the waiting list looks currently, and then when we make these changes to the resources that we have, what does it look like then? So that's kind of where we're aiming to get to. It would have taken a lot longer to run that in the presentation today, so we have kept it shorter, but that's where we're hoping to kind of end up with it. So we do think this is something that can be used for my service, but also for hopefully other services as well. We know that within our service there's going to be expansion. We're looking to treat 25% of the population, so these numbers are going to be increasing. And we're also looking to increase our face-to-face provision and really see what patients are also wanting as well. Are they wanting to stay with online therapy? Are they wanting more face-to-face? And that's where we can hopefully use this tool to allocate resources efficiently. We are presenting it to more senior management within the trust soon, and we're handing it over to a data modelling team within Dorset as well. Yeah.
Brilliant. Thank you very much, all of you. Really fascinating and such an important area, I think, that clearly is struggling so much with waiting times. I think that having a tool like this is an excellent example of how things like discrete event simulation can really help to unpick some of that and see how things might be able to improve. So I think it's a fantastic application. And you said, Casey, about how you weren't experienced in this kind of stuff before. I think it's remarkable that how far you've come in developing something like this. So absolutely should be proud of yourselves. I think really, really good work.
We can give you guys the link, by the way, I was going to say, but we just couldn't give it to you before because the runtime gets massive if other people are looking. So yeah, no, that's good. That's a good plan. Fantastic, and hopefully we'll be able to do that with most, if not all, of the projects that we'll be able to over time. I know a lot of the teams are uploading their stuff to GitHub and various other places. So a lot of these models, hopefully, you'll be able to play with yourselves and feed in your own data. And it's part of the spirit of HSMA that we encourage the teams to share the work and share what they've developed to allow other people to either use or indeed adapt what they've developed. Brilliant, thank you. Okay, so let's move on to the penultimate presentation for today. So we've got Angel and team who've been looking at, again, another discrete event simulation, but this time looking at delays in cancer treatment.
Hi, this is Maya. I'm a service improvement and business manager at Dartford and Behavioural NHS Trust. I have it supported by my team, Jim and Hannah, and our mentor, Luca. We are planning to look into the model for understanding what's happening with all of the cancer patients' pathway. As you may be aware, all of the hospitals are dealing with the different backlogs for the cancer rates. And based on the national target for the treatment of cancer patients, all of the patients, when they refer to a hospital for treatment, to receive their first treatment, they need to be 62 days. And 80% of them need to be treated within these 62 days. And our aim of this project is to reduce the amount of time from referral to first treatment to meet the national target for 62 days by identifying key bottlenecks in pathway. By creating this test model, we wanted to see where is the pinch points, why performance target is being missed, and where it can be improved. In the other slide, we show the other slides. As you can see, our pathways, the cancer rate pathways, is very complicated, and as you can see, there is the day 0 to 62 days. All of the patients that are coming from the different pathways, from, for example, GP referrals, A&E, or different types of that, and they are coming through the different investigations from radiology, from the hematology, and different pathways to get their first treatments and getting their investigation. And for the other slides, if I'm showing. So we want to go through these problems and hypotheses. As you could see, if we are not treating our cancer patients, it's affecting the outcome of the patients, and some of the patients, if their treatment is going to be delayed, it affects to their health, specifically the mental, physical, and sometimes it's reducing the quality of life, and it affects to their mortality rate. And our hypothesis in this study is that do we have enough resources, for example, staffing or equipment to reduce the delays in our pathways. Angela is going to continue for this model.
Okay, so out of all the techniques we learned during HSMA, we decided to use the discrete event simulation modeling. We decided to use that technique because it's based on evidence base. It enables us to better understand the process and patient journey. It's a hypothetical process, so we can create different scenarios without any harm and risk to the patients, which enables us to identify knock-on impact of changes to the service. And lastly, because it's of ease of sharing knowledge, it's built on an open source model, which is easy to adapt for different pathways. The approach that we took was we met with different cancer lead services within our trust to scope the project and discuss the patient pathway in detail. We identified different areas of concern from clinical and administrative process. We used 3 years of anonymized patient records pre, intra, and post-COVID. We worked out the delays by splitting into patient and provider delays and focused mainly on provider delays. Next slide, please. So this is a simplified version of how the model was generated, and the output of this model was the mean length of time patients waited for their treatment. So patients were generated as entities as they flow through various processes. So all referred patients will require diagnostic tests, and out of these, X% will be diagnosed with cancer and will need further investigation. And then we'll go on to have discussions within MDT meetings for their care plan, and then will eventually receive their first treatment. Next slide, please. So now we will quickly present a live demo of 5 runs of our model. Jim, if you could bring that up, please. Thank you. So while that's running, we've already prepped the CSV file to show the output that was generated from this run. So as you can see, these 5 runs shows our average time for each stage, from triage to face-to-face, straight to test, staging investigation, time for treatment, and it also shows the full pathway time from the point of referral to treatment. And our average time between these 5 runs varies between 97 days to 168 days. As you can see, it can vary depending on the complexity of the cases and how complex the treatment pathway would be. Now I will hand it over to Jim, who will talk about the challenges we faced during this project.
So I'm going to stop this. We wanted to just show you the code, and there's a lot of it. So I'm going to stop it, but we wanted to show the outputs of it. We've actually run this for 100 of the different resources, 100 runs to get it through. So some of the implementation challenges we've had around that are people work 8 hours in a day, they work a 5-day week, they don't work weekends. So they all have an effect on time as well. Different patients will get different priorities at different points of the journey. So that was another of our challenges. Branching pathways. So if you saw in the slide 3, we've got a lot of branches. We branch at the beginning from triage, and we also branch around MDT and cycle around a few times. And the MDT challenge for us in particular was quite difficult because we were it was probability over probability of people left. So to use the example, if there's 100 people, the first probability test would take 49 people out and leave us with 51, and then we'd have to do a probability on what's left to get them back to try and pick out sort of the MDT cycle. So the mathematics in that was quite challenging. It wasn't sort of, it's the same each time, it's a different probability of increasing up. In terms of the results, so this is from the 100 run results we did. Really did reflect quite well on the Gloucester data that we've used. It's in days, which is probably different to what a lot of other people have done, which was in minutes when you've seen the previous days. So for triage, we expect it to be very quick. And at the highest and worst on the runs, it was nearly a full day of 9/10 of a day. But it's pocketing around sort of usually a quarter of a day to get it. So as soon as the referrals are coming in, the team at Gloucester are getting them out. In terms of face-to-face, we jump out of small decimals now into actual days that start at 100 and go down to 0 here. Again, you can see the pattern kind of straight through the middle, again, which reflects quite well what we saw out of the Gloucester data of, yes, predominantly a lot of patients are breaching the 62-day, and something needs to be done with a bit of what-if analysis to bring those days down. But as you can see, a 70-day wait to get a face-to-face isn't really meeting the 2-week wait, and some of those face-to-faces obviously will be after we've done the initial first test. So overall, in terms of taking that to the pathway wait days for first treatment, we've got a diagram at the bottom here. Again, this one's sort of showing down the middle about 100, 120 days for our process to get the patient from triage through to that first treatment. We felt this reflected quite well, and sort of the breach times on them are, just check. Sort of the minimum was about 15 days breach. The maximum breach was going to take us well over sort of 50, 60 days breach. The average came in at about 40 days over the 62. So we felt, again, from doing the multiple runs, we were getting kind of close to what we wanted to do, which would take us into our next steps of what-if analysis for additional resource, additional capacity, things like that. So the next steps for us, we've predominantly got something, a basis to start with. We've done a lot of analysis outside in Excel to begin with. We need to do more analysis with graphs and graphical representation that is useful to the end user, not to us. So a lot of what we've done makes sense to us, but our target really is our Cancer Alliance teams, our fellows in BI at Gloucester and Morecambe Bay, really to get this to be something visual and effective so that they can make decisions. So those are our next steps. We realize we may have to do some deep dives into multiple disciplinary process, diagnostic steps, just to understand maybe some of the weights there. We're at the stage of doing more what if. I think we've got the model to a place where we're happy that it mimics what's going on now. We now need to do our what if analysis. Very keen to share the code, and our next steps would be to do the breast pathway, which was originally on this project, but we decided to just focus on colorectal to begin with, just to get something out there. Long-term plans, both me, Angel, and I think Maya may be carrying on with this after, and we're keen to find others that are interested in this area post HSMA 4 to get involved with us in terms of coming up and discussing these things after, and if it's something that anyone's interested in joining or being involved in from a cancer point of view, we're looking to do other cancer pathways, like I say, breast being first, but skin and head and things like that. We're keen to adapt what we've got and take it forward. A few references here about how we got our data and the fact it was anonymized and where we found some of our statistics. Again, if there's any information or slide decks or code or anything you want to talk about, feel free to put it in the chat or come to us at the end of the session. Thank you.
Fantastic. Thank you very much, all three of you. I think that, again, and a fantastic presentation, such an important area again, and some really promising results coming out there from in terms of potential ways forward, I think. And fantastic to hear that you're very keen to continue this and to work with others. So hopefully you'll get some interest, and other people will sort of come forward, because I think there's a great demonstration of what we do and the collaborative spirit that we encourage. So
I suppose that the final thing we didn't say was big thank you to Luca, if he's on the call. Couldn't have done it without our mentors, and the mentors are incredible.
Fantastic. No, that's great to hear, and it's big shout out to the 11 trainee mentors that we had supporting us, because people like Luca and others who have allowed us to deliver such a large scale program and support so many projects that you're hearing about today. So we move now on to the final presentation for today. This is Irma from Oxford, who's done some fantastic work looking at discrete event simulation again, this time looking at a backlog in children's neurodevelopment assessment, with extensive backlogs and hopefully some real signs of a promising way forward. So over to you, Emma.
So as you said, my project was around using discrete event simulation to tackle the long waits and the growing backlog for children requiring neurodevelopment assessments, so autism, ADHD, and comorbid. I'm from Oxford Health NHS Foundation Trust. So what's the issue? The service is not able to keep up with the demand. We're looking at Oxfordshire and Bucks, but also across the country, as illustrated in the figure, which shows the increasing number of patients still waiting for an assessment over the past 2 years. Moreover, the average waiting time has increased by more than 50% in the past year, with patients waiting more than 2 years on average. What impact does it have? The impact on patients is that children are not receiving the support required, which means a deterioration in mental state. Parents are expressing concerns and lack of support while waiting for an assessment. The impact of service is longer waiting times means longer assessments, and complaints impact on managerial time and team morale, and we are losing staff to the private sector. So I've split this in what do we actually need to know on the whole process. So first of all, we need to understand the current pathway, which was quite tricky. We then needed to identify where are the main bottlenecks, the long waits in this pathway. And then we wanted to, okay, so now that we know the main bottlenecks, how do we actually manage the ongoing demand, and what do we need to do in order to maintain a steady state and avoid a backlog from growing? And then finally, we know we already have a huge backlog. So in addition of keeping a steady state, what do we need to have in order to eliminate the backlog that has developed as a result of the ongoing demand not being met? So these are the four kind of areas we wanted to address. So the pathway on a high level is referral gets sent from GP. It goes to SPA, single point of access, so triage the referral to the NDC team, which is sends out the questionnaires to schools and parents. Schools and parents return the questionnaire. The clinician determines the complexity. If it's complex, there are several face-to-face appointments with specialists. If it's simple, sometimes there's just digital appointments. And at the end, it goes back to clinicians to feedback to parents, signposting, obtaining referral consent, and so on. So that's kind of on a very, very high level. Then we looked at, so this is the pathway in a more detailed level, which also shows now the 10% trimmed mean waiting time in days between the different steps happening. So I won't go too much into detail here, but one of the things we wanted to look at was there were issues around, well, there were some questions around how long does it take to actually return the questionnaire back from parents and schools. And actually that waiting time wasn't that big at all. As you can see, it's only 35 days compared to, you know, other waiting times in the process. So we kind of wanted to first look at this section here. And so it's the section where the episode gets opened to NDC by SPA, and then it takes almost 2.5 years for the questionnaire to be sent out. So what we actually saw that on average 4 questionnaires get sent out per day, and it's actually an artificially induced wait because the problem lies somewhere down the line in the pathway, because there's just not enough capacity to address all the questionnaires if they send out hundreds per day or so. So by focusing on further down the line, the pathway, we would address this long waiting time here. So it's just what I said about the 35 days and the 648 days. So by focusing down the line here, we are actually looking at this pathway, and this is what we designed in the model. So just going back to the model, so we are looking at referrals with completed questionnaires arriving as 4 per day. So that's kind of the entry point of the model. And then appointments get booked, and we can see who is booking the appointments. In blue, we have the trimmed mean now in hours. And then we have the split if it's ADHD, autism, or comorbid. So if it's ADHD, for example, after the appointments are being booked, there's an average of 8 appointments that take place, and it lasts about 40 minutes. And after that, there is a final appointment with parents to feedback and then close the referral. Now, in all of these different sections, we identified who is actually doing those appointments. So for ADHD and autism, we have on average 8 appointments. For comorbid, we have 10. But the thing is that we have staffing, like we have the admins, we have lead clinicians which are non-comorbid. So these are lead clinicians who are doing ADHD and autism. We have lead clinicians who can do comorbid as well as non-comorbid. We have the second assessors who can do comorbid as well as non-comorbid. And we have second assessor who only can do ADHD. We also identified that out of those, for example, for ADHD, out of the 8 appointments, 60% are delivered by lead clinician and 40% by second assessor. Sometimes they also deliver them together, but most in the data what we saw is most often it's, you know, the split is 60-40. Similar with autism, it's 70-30, and with comorbid 75-25. I wanted to mention that the model is a simplification of the real world. The pathway itself obviously is far more complex. There are several assumptions that I will go through later, which are simplifying the model. Right, so what changes need to take place in order to keep on top of the ongoing demand and see the patients within an acceptable time? So for this, I would like to demo the tool. Give me a second. Right, you can still see my screen, everything okay?
Yeah, that's fine.
Okay, great. So I thought I include in the tool just to show the model and the assumptions, first of all, because I think it's really important to actually have to be very clear on the assumptions. So I have summed up the staff whole-time equivalents, and I'm assuming the staff are spending 2 hours per day on appointments. and are busy with other things, but at the same time. So all staff are at the same time spending 2 hours per day on appointments. And why 2 hours? That was what I saw in the data. So out of the whole data, spending actually just 2 hours on clinical appointment time. I didn't include any holiday or sick leave, and all staff are unavailable at the same time. There's also an MDT discussion that happens regularly for comorbid cases, which I haven't included, and I can go into detail later in questions why I haven't included certain things. But if I just run the current model as it stands, so here again, I'm repeating kind of the picture of the model, and I'm running it for the last 5 years, and I'm using 10 runs. We also used 100 runs, but we didn't actually see much of a difference there. So what are the charts showing here? So this is the whole journey time. So what I mean by whole journey time is from the moment they enter, the completed questionnaire gets returned, because that's our model. So from the moment the completed questionnaire gets returned to the moment the referral is closed. That's what I mean by whole journey time. And then I'm splitting it by ADHD, autism, and comorbid, and it's the waiting time in days, right? So with the current research that they have, the waiting time in days, which is kind of similar to what we are seeing in the data as well. So one interesting thing I kind of saw immediately was that there is something in common between autism and comorbid, so because the numbers are high. And when I looked at overall how much of the demand they're meeting with the current research, they're actually only managing 61% of their demand. So their backlog is growing by 2 every day. So in 1 year, you're going to have 397. So that's kind of the message. But there's something interesting between autism and comorbid. So when I then looked at staffing, who is actually delivering autism and comorbid? So it's either lead clinician, any, which means lead clinician, non-comorbid, or lead clinician, both, and second assessor, both. And here it's lead clinician, both, and second assessor, both. So if I, for example, increase lead clinician, both, to 6 and run the model and see what happens there. Sorry, that takes a bit of time to run. Not too bad. So you can see that this didn't actually produce much change. So this wasn't really my bottleneck here. So I'm going to go back here. The other common thing here was that the second assessor, both, they're delivering both appointments for autism and comorbid. So if I increase second assessor both to 3 and run the model and see what happens then. So remember, our waiting time was in hundreds of days. And I'm just going to look at what happens if I increase the second assessor both. So this is now the waiting time split again in days, but it's down to, the whole waiting time is down to, 20, 40, 60. I do have here statistics about the median waiting time and so on. So you can see that by recruiting just one second assessor, both, it reduces dramatically the waiting time. However, so you can see also they are managing 99% of the demand by this, by only recruiting one resource. However, ADHD is still quite high here in number of days. So if I increase ADHD, second assessor ADHD, and run the model, then I can also look at the waiting time and compare it. I should learn to talk while it's running. right? This is now down as well. So even though they were managing the demand, even with that previous resource with 3 second assessors both, the ADHD waiting time was still high. Now they're all very low. So this is what is shown by managing the existing demand. There's obviously still the backlog. Just wanted to summarize what we just saw, because I think it's more dramatic when you see it this way. So by recruiting a second assessor both, previously they managed, with the existing resource, they managed 61% only. By recruiting a second assessor, they're managing 99%. The waiting time overall, was I think median was about 300 or so, which is down in tens by recruiting second assessor. So that's the question around existing demand. Now, in addition to maintaining that steady state, how do we eliminate the backlog that has developed? So again, I'm gonna go back to the demo. So I'm gonna here include a clear backlog of 1,470 patients in 5 years. If I run it with the one that was great for steady state, and see what happens there. And I don't actually have 2 screens because I want it on the other screen to actually. So again, with introducing the backlog, they are managing only 58% with that resource. I actually identify what resources needed in order to manage it for in 5 years, the backlog, to reduce the backlog. So it's 52544 is one of the options. 52544. Run that. But what I wanted to highlight here is that there are possibly different combinations that would help to reduce the backlog, and I would like to let services decide what the best way for them would be, because recruiting someone long-term or short-term, and it might be that different decisions might be taken place if you take into that into consideration. So we're providing a tool for the services to decide what's best going forward to recruit. So this is one of the options with this to reduce the backlog here. So I kind of wanted to go to the main challenges. So the main challenges in this project were actually not so much the technical side, but more mapping out the whole pathway. And it was, I think, mostly due to the lack of clear documentation and obviously staff and process changes and who does what, and different people do different things in the whole process. So it was also surprising to see that several sections of the pathway are not recorded in the main clinical systems, but rather in Excel spreadsheets. And then there were also a significant amount of incomplete data, which we had to deal with. So next steps, the findings and the model has been presented to the stakeholders, including service managers, clinical and operational leads, service heads, and the trust board. And discussions are already taking plans on how the model is used to support any improvement work in the service. It's worth noting that the current model is developed based on Oxfordshire NDC pathway. We are now looking into if we can implement a similar model with the Buckinghamshire pathway as well. And the tool is available to use as well to everyone. Thank you.
Fantastic. Thank you so much, Emma. An absolutely amazing story, I think, of What I love about that is that you've kind of exposed the kind of fundamental problem in the system. What was so interesting was that where they thought the delay was, actually it didn't unpick the fact that there was an artificial delay in there because of the delays further downstream. And so using the modeling to really understand that, and then so powerful to say, well, actually that we can see our why this is such a mess, because the waiting times are spiraling out of control. And actually, to get that back under control, we only need one more of this resource, and that will get things back under control. And then I love the fact that you've then added in the if you also want to clear the backlog in X amount of time, then this is how you need to do it and how you need to resource it. So yeah, absolutely fantastic. I think it's a great thing and so important for so many services, I think now. So such an important issue you've covered. But just before people disappear off, I just wanted to say a massive thank you again to all of our HSMAs who've presented today. I've been sat here for 4.5 hours beaming with pride. Genuinely, the work that you have all done is absolutely astonishing, and it never ceases to amaze me the amount of impact and fantastic work you've generated, and sometimes it can be difficult for you to see that, but just think back to 12 months ago when I was showing you how to print the words "Hello World" on the screen, and now you're developing tools, discrete event simulation models, geographic models, machine learning algorithms that are having real impact, and you're transforming the way in which your organizations are dealing with this. So I have to say a massive thank you to all of you. It's been a great pleasure to work with you all, and I cannot wait to work with the next cohort, but also to hear about the fantastic work that you continue to do, taking these skills forward. And a big part of HSMA, as I say, is building up this community. We've now got over 300 people on our HSMA Slack workspace, and obviously that's growing every year, and you are forever welcome to be part of that community, and we'd love to hear about the work that you continue to do and engage with our HSMAs moving forward. So a massive thank you to all of you. Fantastic presentations today, and also thank you to everybody who's come along today as well to listen. I appreciate nearly 5 hours we've been going now is a long time to sit on Zoom, and it was so lovely to see that we retained so many people for such a long time, and I think that speaks volumes of the interest levels in the presentations that have been delivered. So thank you for coming along and hearing about our HSMAs and their journeys and their learning and the impact that they've had today.